no doubt that a uterine septum is a very well established cause of recurrent pregnancy loss, recurrent abortion, preterm labor. Despite a lot of talks and controversy, should we treat or not and how to treat, but there is a substantial evidence that if you correct the uterine cavity and reconstruction of a septate uterus properly, there is an obvious improvement of the reproductive outcome. Like any surgical procedure, if the procedure is done badly or inappropriately, so definitely you'll not have improvement. You don't have a positive outcome. So let's stay away from the debate to do or not to do, and let's learn and know how to do. You can use a bipolar or monopolar knife. Have a panoramic view to draw a map, a GPS plan in your mind. We start at the most inferior part of the septum, at the apex. Move from the electrode from one side to the other side. This steady movement will allow clean, stable line of cutting. The pushing technique is not favorable because every time you push the electrode, you touch the tissues at different level. So, but here you can see very well the retraction of the fibers. So this answered the question of many of my colleagues and my students who said, Osama, we're very confused because lately there was an opinion that septum should be excised, removed. Nothing is removed. You see the tissues? These are muscle fibers. Only at the edge, at this part, it's only fibrous. But when you move to the center, it is muscular and vascular. By color Doppler, the septum is very vascular tissues. And you will see it now. You can see the bleeders, okay? So, you are joining me now in a real-time performance of a septum surgery. And you can obviously notice that once you have a good, clear, panoramic view, you can perfectly finish the procedure in less than 10 minutes. Why some people take longer time? Because they don't see well. And they cut in different directions, in wrong directions, and they keep going in and out, and they don't see well. The chance of fluid overload is minimal. When you finish in less than 10 minutes, there is very minimal fluid overload. And what can I tell you? I don't have a study to stand on, but my personal work, my personal experience, which is published on YouTube, more than 2,000 videos, I've never seen a significant fluid issue in cases of septum reconstruction. So, as we climb up, we don't cut in the same level. This is the most important statement I say. When I started at the apex of the septum and climbing up, the level of cutting varies and different. Sometimes I go 2 millimeter up, 2 millimeter down. Guided by what? Guided by this. Look, guided by the tissue retraction. My dear friends, embryologically, fusion of two Mullerian ducts, if failure of disappearance or migration of the midline structure, this results in the septate uterus. So hysteroscopic surgery resume the unfinished job of embryology. It is not disappearance of septal tissues. Embryologically, it is migration. You see the migration? This is my theory that embryologically the septal tissues migrate toward the anterior and posterior wall to finish or to end with one normal triangular cavity. You see the vascularity of the septum? So, I'm sorry to say that for a long time we used to say absorption of septal tissues embryologic. No, it's not absorption. It's a tissue migration. And hysteroscopically, we continue what has been not done embryologically. This is just touching the bleeders so you can continue. Again, I repeat, the most important technical point in septal surgery is that the level of cutting is changing, is dynamic. 2 millimeter up to like you are on a boat floating on waves. Can you get my analogy? You see how you imagine how the waves float the boat up and down. you can see this very nice at the end of the procedure. At the end of the procedure, there is no hanging tissues, there is no residual tissues. And I invite you to look at the original endometrium that she had at the cornea and appreciate that with the new surface area added, okay? So at the end, near the fundus, you do very fine strokes. Keeping the tubal ostium is your landmark to tell you that's enough. Septum surgery is a plastic surgery. It's like rhinoplasty, it's like mammoplasty. The surgeon keep evaluating the shape of the cavity, the thickness of the anterior and posterior wall, and at the end you have a beautiful normal cavity. There's no need to use any intrauterine device or a balloon, or no need for hormones. Complete healing within 2-3 months. This is Usama Shawki. Thank you very much.